Hello, everyone. It's noon. Grab your lunch. Come on in. We got a good talk today. Guess this is getting broadcast to many different sites, encouraging everyone to grab your lunch. Okay. We have Wayne Caton, who many of you know. He's part of our program. He's mostly based at the U. And let me give you some information about him. Wayne Caton is professor of psychiatry, director of the Division of Health Services and Epidemiology, and vice chair of the Department of Psychiatry and Behavioral Sciences at UW Med School. He's the director of an NIMH-funded National Research Service Award Primary Care Psychiatry Fellowship that has successfully trained psychiatrists and primary care physicians for academic leadership positions. Dr. Caton is internationally renowned for his research on developing innovative models of integrating mental health professionals and other allied health personnel to primary care to improve the care of patients with major depression in primary care. He has also been a leader in research on the prevalence of anxiety and depressive disorders in primary care, the relationship of psychiatric disorders to medically unexplained symptoms, such as headache and fatigue, and the impact of depression and anxiety on patients with chronic medical illness. Dr. Caton has been awarded the American Academy of Family Practice Award for excellence in teaching in primary care numerous times. He has also been awarded the Academy of Psychosomatic Medicine Research Award and the APA Senior Scholar Health Services Research Award, and the Depression and Bipolar Support Alliance Gerald L. Clairman Senior Investigator Award. He is editor-in-chief of General Hospital Psychiatry and is honored by being one of the Web of Science highly cited authors. Dr. Caton has written over 500 peer-reviewed journal articles and chapters, as well as Panic Disorder in the Medical Setting, a book for primary care physicians. He has recently edited a book entitled Depression and Diabetes, and has written a self-help book for depressed patients titled Depression, Self-Care Companion for Better Living. Dr. Caton.
Thanks, Dr. Ram. I actually feel kind of lucky to be here today because yesterday I was sort of laid low by one of our GI bugs, so I'm a little bit low energy today, but I'll do my best. What I'm going to describe today is a series of studies that started with some epidemiologic work about the bidirectional interaction of depression with a chronic disease, and we use diabetes as the disease that we've studied, and then describe our first attempts to improve depression care among diabetics after showing the adverse effects of depression on diabetics, and how that led us to the ideas of TEAMcare, which I'll spend most of my time on today, which is an integrated program to provide care of both medical illness and psychiatric illness in people with diabetes, heart disease, and comorbid depression. I wanted to start out by acknowledging the wonderful health services team that I've worked with for many years, including Michael and Coriff and Elizabeth Lynn, as well as one of our own faculty, Paul Chianowski, and that Group Health has been instrumental in allowing us to use their clinics as laboratories to do many of these studies, and the NIMH has funded these grants over the course of over about a 12-year period. I'm going to start out by talking about a case that actually was a case within our TEAMcare study, and then weave that case into the rest of my presentation today. So this is Mrs. K, who is a 45-year-old computer programmer. She has a 5-year history of type 2 diabetes. She has a history of childhood abuse. She has had recurrent depressive episodes since her teenage years. She's pretty massively obese with a BMI of 51, greater than 30 kilograms per meter squared would meet our obesity criteria. She has a prior history of smoking but has been able to quit over the last 5 years since being diagnosed with diabetes. She also has been diagnosed with sleep apnea and uses a CPAP machine regularly. And at baseline, her PHQ was 20, which would indicate severe depression, and her hemoglobin A1C was 9.6, which indicates her blood sugars are in very poor control. Below 7 would be what we would hope in terms of optimum control. So we'll remember this case, particularly the last two lines, the PHQ-9 being 20 and the hemoglobin A1C being 9.6, and I'll be weaving this case through the lecture today. We published an article in 2003 where we proposed that there really are bidirectional interactions between depression and chronic medical illnesses, particularly illnesses like depression and heart disease. And the way this model works is that depression often begins in teenagehood or in early 20s, and the studies show that depression prospectively is associated with developing the smoking habit and having trouble quitting smoking. It's associated with becoming more sedentary over time and with becoming more obese. It's also associated with a variety of psychophysiologic changes. There's more and more evidence that depression is associated with decreased insulin sensitivity, increased autonomic nervous system tone and dysregulation, increased inflammatory markers, and increased cortisol. And perhaps because of both the health risk behaviors associated with depression as well as the psychobiologic effects of depression, it leads to early development of illnesses like diabetes and heart disease. So we've found in our group of about 4,800 people we've been studying for about 5 years at Group Health that the depressed diabetics get their disease about 5 to 6 years earlier. And that may explain why depressed people are more apt to die of the same diseases as the rest of their population, like heart disease and diabetes, but they're often getting them earlier. And once they do get them, depression is associated with poor adherence to medical regimens. So, diabetes, one of the reasons we chose diabetes to study is it takes a lot of care to take care of your diabetes. You're supposed to follow a special diet, exercise more, you have to go on 4 or 5 pills to manage it. You're supposed to check your blood sugars regularly and alter your doses based on that. And people with depression simply can't do that, and I'll show you some evidence of that.
If you get it earlier, does that mean you'll die earlier?
Yes, and I'll show you some data about that too. Yeah. So one of the unfortunate things with both heart disease and diabetes is that comorbid depression raises your risk for mortality in those diseases once you get them. And I'll show you some of the data we have from Group Health about that. And again, because of the lack of adherence, you're more apt to get poor medical symptom control, increased functional impairment, increased complications of medical illness. And I'll show you some data showing that our depressed population over 5 years are more likely to develop a macro and microvascular complication, as well as increased mortality. And then again, if you think about diabetes, losing a leg, losing your vision, if you have a propensity towards depression, it's going to lead to a recurrence of depression or a worsening of the depressive episode, and that's the bidirectionality. Again, in terms of medical morbidity, we know that psychiatric illnesses, including depression, are probably associated with more medical morbidity and earlier development of medical morbidity based on maladaptive effects on the HPA axis. With depression, people have shown that depression is associated with increased development of centripetal obesity, which is a risk factor for both heart disease and diabetes. Autonomic nervous system dysregulation, increased cytokine levels, which may make you more prone to stroke and other illnesses. It's also associated with the health risk behaviors I talked about earlier, the smoking, the sedentary lifestyle, and the obesity. The lack of self-care. People with diabetes and depression and other medical illnesses and depression have trouble following their self-care to take care of themselves. And then we've all become sensitized over the last decade since the advent of atypicals that the very medicines we use may add to or cause the problem in terms of obesity, metabolic syndrome, diabetes, and heart disease. Again, one of the ill-known facts in the United States, or less-known facts, is that behavioral risk factors like smoking, obesity, and sedentary lifestyle are estimated to actually be involved in 40% of all deaths in the United States. And again, depression is linked to all three, so is bipolar illness, so is schizophrenia. There's a large healthcare study called the Women's Healthcare Study that many female researchers in Seattle have been involved in. This is a cohort of 98,000 women being followed from middle age to older age. And what they showed in this study in 2004 was the depressed populations compared to the non-depressed in this sample of community women had higher rates of smoking, greater lack of exercise, or more obesity, or higher proportion with obesity, a higher proportion with type 2 diabetes, higher cholesterol levels, and higher rates of hypertension. Obviously, all of those don't bode well, both in terms of diabetes and heart disease. And again, meta-analyses have also suggested that people with these comorbid, say, depression and heart disease or depression and diabetes are more likely to be non-adherent with their medical regimens. And this is a meta-analysis by Robin de Matteo that was done in 2000, which has been replicated at least once over the last 10 years, which showed that depressed populations compared to non-depressed were 3 times less likely to follow adherence to their medical regimens. And our group, starting in the early 2000s, started to follow a cohort of group health, which is called the Pathway Study. Excuse me. This was a study of 4,800 people who were sampled at group health that we've followed now for 5 years. 4,200 gave us permission to connect with their medical records, that is, connect our survey data, which was a 20-page survey, to their medical records. And we began to look over time about the association with depression and adherence with diabetes. And what we've shown here is there's a very nice dose-response relationship. As you go from no depression to minor to major, there's an increasing number of diabetics smoking. Now, diabetics, every time they go to the doctor, get warned about smoking because cardiovascular disease claims 50% of their lives. That is, 50% of the mortality due to diabetes is due to cardiovascular disease or stroke. And so the doctors really push this. But you can see the depressed people, probably because they also have more trouble quitting, are more likely to be smokers. And it's about double the rate in the majors compared to the none. We also found that the depressed, despite this is largely a type 2 diabetic sample, 96% are type 2s. And despite them being selected, in a sense, for obesity, the depressed population are about 20% more likely to meet obesity standards, that is, a BMI of 30 kilograms per meter squared or greater, such that around 70% of majors versus 50% of the folks with diabetes who are not depressed meet these obesity criteria. How about their blood sugar control? Well, what these data show is that there's a higher percentage of people with depression who have hemoglobin A1Cs above 8. And again, the guidelines would say you should be below 7. So these are people who are well above guidelines. We also looked at, one of the unique things that we can do at group health is look at whether people fill their prescriptions in a timely manner. So if you got 90 days of metformin, we could look at your next refill and see, did you get it at 100 days or did you get it at 89 days? And we could estimate the percent of non-adherent days by people not filling in a timely manner. The frightening thing is it looks like all diabetics don't fill their pills in a timely manner, but it's significantly more common in the depressed in their 3 key meds, the oral hypoglycemics, the statins or lipid-lowering meds, and the ACE inhibitors. We followed up this initial, more cross-sectional survey by studying the effect of depression on medical outcomes over a 5-year period. And we were able to use a lot of the automated data at Group Health to look at that, including ICD-9s of the type of complications we were looking at, macro and microvascular complications, as well as Washington State mortality data. And I'm going to only give you an overview of that today, and then we're going to switch to some of the intervention studies. And the most important column here to look at is the major depression column. And what you see here is these are comparing people with diabetes, largely type 2 diabetes, who have comorbid major depression, and we're comparing those to people without depression who also have diabetes. And what you see is in the comorbid major group, over a 5-year period, they're 33% more likely to get microvascular complications. That would be something like retinopathy or nephropathy. They're 38% more likely to get macrovascular complications, i.e. a heart attack or a stroke. They're 50% more likely to die over the 5-year period. They're twice as likely to get a foot ulcer over the 5-year period. And again, that bodes poorly for the population because foot ulcers is often a harbinger of developing an amputation, getting a BK amputation. And then I think our maybe most exciting epi data that we've looked at recently is we looked at whether having comorbid depression was associated with development of dementia. And what we did in this study is we left out the people in the first 2 years who develop dementia, because depression can be a prodrome of dementia. And we still found that depression was associated with over a 2.5-fold likelihood of developing dementia in these diabetics. And we've known for years that both depression and diabetes are independent risk factors for dementia, but these data show that in fact when you have them together, it's a pretty bad adverse synergy. And again, we showed this in our 4,800 diabetics, I just replicated this data with 19,000 diabetics at Kaiser, and we found virtually the same findings in that study as we found in this study. So again, very interesting finding. The other fascinating finding from that is the diabetics who were on insulin were somewhat protected from the effect of depression. So the risk of depression was about twice as great in the diabetics who were not on insulin compared to the ones that are. And probably at some point this year you've heard or have heard Susan Kraft's data basically showing that nasal infusion of insulin may be protective against worsening or causing dementia. So there may be a story here that's kind of fitting together. Now, we came away from these epi studies saying to ourselves, well, if we could only improve the care of depression, maybe what we would see is people would begin to improve their self-care with diabetes and begin to lower their blood sugars and quit smoking and take care of themselves better. And so our first study, which was published in 2004, the Pathways randomized trial, randomized 329 largely type 2 diabetics at Group Health to basically a collaborative care depression intervention that only focused on depression improvement versus usual primary care. And the intervention is very similar to what Jürgen Unitzer did with the TEAMcare Study, where the patients who were in the intervention arm all got behavioral activation, where we tried to get them back to doing positive activities they'd stopped doing before they were depressed. And then in addition to that, they had a choice of either starting with problem-solving therapy or starting with antidepressants. And then if they weren't getting better with antidepressants, we could augment it with a different antidepressant or problem-solving and vice versa. And nurses delivered this intervention. They were supervised regularly, weekly by psychiatrists who would make recommendations about meds that they would bring to the primary care system. What was the result of that study? Well, not surprisingly, we had a nice effect on depression. I would say it's a modest effect on depression. The intervention was associated by 6 months and continued at 12 months with a significant improvement in depression compared to usual care. The intervention stopped at 12 months, and we continued to follow the population, these two populations, to 24 months. And at 24 months, the intervention group is still better in terms of depression outcomes. The disappointing part of this trial is we found no effect on hemoglobin A1C. You can see there are parallel lines. And these people started relatively low to begin with hemoglobin A1C of about 7.8. So there wasn't that much room to move. But we had expected some movement here, and this was a disappointing finding in this trial. The other thing we found, which was more encouraging in this trial, and we found the same in the 400 diabetics who were involved in the IMPACT trial, was that the intervention, there was a cost offset effect basically. The cost of the mental health intervention was offset by savings in medical costs over a 24-month period in this diabetic population. And this was really the first time we had seen this in a replicable way, that is, providing better mental health costs, better health quality of mental health treatment and outcomes could save you money on the medical side of things. And in Pathways, we were actually able to extend this 2-year sample to 5 years, and we published an article in Diabetes Care showing that not only was there cost savings in year 1 and 2, but it actually extended to year 5, 3, 4, and 5. You continue to see the cost savings, eventually getting them to around $3,000. Well, that made us think a lot about what had happened and why weren't we seeing changes in the self-care in this population. And we came up with the idea that treating depression and other mental illness is a necessary but not sufficient step in improving health risk behaviors. So again, those of you clinicians, if you get an outpatient who's depressed but is 70 pounds overweight and smokes and is a couch potato, you can usually treat the depression. You can put them on meds, you can add psychotherapy, you can treat them with CBT, and you can get most people better. But at the end of the day, they're going to be a happy person who's a couch potato and smokes and is sitting on the couch all day, right? And you're going to have to, in other words, treating depression is a necessary first step, but probably not sufficient alone to get them to change health risk behaviors. So that was one of the major things we came out of this study. The other thing in reading the literature is that approaches for collaborative care now have been tried, or disease management, in multiple single chronic illnesses like diabetes, asthma, CHF, and depression. However, the most costly and complex patients, in fact, often have multiple comorbidities, and because of that, they do worse with the medical system. They're very expensive. They do worse with adherence because they're on multiple meds, and they have worse outcomes. And we did some searching about Medicare data, and it turns out that if you look at Medicare recipients who have either depression or diabetes or heart disease, these are which are three of the five most common illnesses among our Medicare populations. Fewer than 4% of Medicare beneficiaries with any of these three illnesses have no other comorbid conditions. And in fact, 80% of those with CHF, 70% with depression, and 56% with diabetes have 4 or more chronic conditions. And so really the norm is this multi-comorbidity, but most of the interventions that have been developed until this time had really been worked on one medical illness or one depression. It reminds me, when we did our first depression study at Group Health, one of the doctors came up after me and said, "Wayne, this has been a great study. My depressed patients have really improved." We had seen about 15 of her patients in the study. And she said, "But, it would be great if you could help me with their other illnesses, because I'm a geriatric internist, and all my patients have 4 or 5 illnesses, and they're often not doing well in these other illnesses as well." In other words, a multi-collaborative care intervention would have been something that she would have preferred and liked. Again, in thinking about our new intervention, there's some fascinating data that came out from Kaiser, where they looked at a population of close to over 160,000 patients with diabetes. And again, what they were looking at in these diabetics is they looked at people who were clearly above guidelines on one parameter, either hemoglobin A1C above 8, systolic blood pressure greater than 140, or LDL greater than 130, all well above guidelines. And what they did is they followed them for a year to try to estimate how much of their poor medical disease control was kind of patient-empowered, i.e. poor adherence to meds, versus how much of it was that the doctor wasn't intensifying treatment. So if they were on 50 of hydrochlorothiazide and their blood pressure wasn't high, how many people didn't have an increase in blood pressure meds or a change in blood pressure meds over that year? And the fascinating part of this was we often blame people having poor control and poor adherence. And you could see it's there, 20 to 23% you could blame on poor adherence, which you'd probably guess is more of a patient-oriented problem, although not entirely, because we're responsible as physicians. But you could see 30 to 47%, depending on which of the meds, had no evidence of treatment intensification. So in thinking about our new study, yes, we wanted to focus on adherence, but we realized we really needed to do something about intensification of treatment. So in thinking about this new study, which became known as the TEAMcare Study, we came up with this idea that in primary care there are likely illnesses epidemiologically that occur in natural clusters. What did we mean by that? Well, we meant illnesses with a high prevalence, high comorbidity, and bidirectional adverse interactions. And in the clinic I work in, I still work a day a week at the Cherry Hill Swedish Family Medicine Clinic. The 2 big clusters that we have in my clinic are kind of the metabolic syndrome cluster, obesity, diabetes, coronary artery disease, and depression. And the other big cluster is the depression, chronic pain, substance abuse cluster, which has become even more of a problem in the last years, partly due to iatrogenic problems, i.e. doctors prescribing too many opiates for the wrong people. It's not that opiates are bad, it's who you prescribe them to, in other words. Adverse selection is what it's known as health services research. So we managed, with several attempts, to get an NIMH-funded study called the TEAMcare Study. And the inclusion criteria for this study is we screened people who had either diabetes or heart disease, who had evidence of poor disease control, because these were people we felt we could move and actually improve their disease control. So they had to have a hemoglobin A1C of 8.5 or above, blood pressure greater than 140 or 90, and LDL greater than 130. And then if they had that, they got screened with a PHQ-9, and if they had a 10 or more, they were eligible for the study. So these people had comorbid depression with either diabetes or heart disease or both, and had evidence of poor medical disease control. We enrolled over time in a rolling admission 14 group health clinics. They went all the way from Olympia to Everett in this study. 150 primary care doctors signed up to consent to allow them to work with their patients in the study. That was 92% of the doctors in these clinics. We wound up screening over 9,800 patients, and we eventually randomized 214. Again, the aim of the study was to improve depression care, and in this study we had to use medical nurses because we were not only aiming to improve depression care, but care of their chronic medical illnesses. And so we didn't teach these guys, these nurses, problem-solving therapy or cognitive behavioral therapy, but they did learn about behavioral activation, and that was part of the intervention, as well as antidepressants. And then we had a major aim to improve their medical disease control to a large extent with intensification of medications. And then we also aimed, based on what patients chose, to improve self-care. So if a patient said they would like to work on their diet and weight loss, that's what we chose, based on what the patient-centered kind of approach was. Again, we had, at any time in the study, 3 diabetes nurses. They'd all had pretty extensive experience in diabetes, although interesting enough, what they told us afterward is diabetes educators, primarily their job before would be to do 1 or 2 sessions with someone who was getting their first diagnosis of diabetes to educate them about the diet and meds and so on, or they followed them once or twice to try to help with their disease management. But they had, in their old job, had no MD supervision, nobody was tracking outcomes, and they didn't follow them long enough to reach guideline levels because they were off to the next patient after 1 or 2 sessions. They were supervised for the depression care with a psychiatrist, and the diabetes care and heart disease care with a nephrologist and family doctors. And we wound up splitting up into teams where 1 psychiatrist and 1 internist worked with 1 team, and a family doctor and a psychiatrist worked with the other. And again, we also had email contact for complex cases to a diabetologist at Group Health. The nurse training involved a generic training that those of us who do case management, like Doug and myself, would say is generic for all nurses. That is, all nurse care managers need to learn some skills in motivational interviewing, problem solving, and behavioral activation. And then in addition, they got targeted training on algorithms for antidepressants, and those were pretty specific for our diabetes population. For instance, in diabetics, we use a lot of Wellbutrin because it doesn't cause weight gain. People often lose weight on it. And also about 1/3 or more of diabetics come in with some degree of sexual dysfunction because of their autonomic neuropathy that they get from their diabetes. And so Wellbutrin is a nice target drug for those who have that. And again, we had treat-to-target guidelines that the nurses used about algorithms for blood glucose, hypertension, LDLs that Kaiser and Group Health had developed and were okayed by the primary care system. Remember the lady I presented, for those of you who came in late, I presented a lady who was pretty massively obese, was referred to our TEAMcare study with a PHQ-9 of 20, severe depression, and also referred with a hemoglobin A1C of 9.6, so in terrible control of her diabetes. And you can see there was a variety of things that the nurse with the psychiatric supervision did. The citalopram was titrated to 60 milligrams initially. Trazodone was added to help with her sleep, and then because she still had some degree of treatment resistance, she was still at about a 12 or 13, bupropion was added. And eventually we actually titrated this lady up to 200 BID of bupropion and lowered the citalopram to 40, which might be wise now given that the recommendations are not to go above 60, to go to 260 or not go above 40, but we didn't know that at that time. And you can see her PHQ-9 is going down nicely to the point where it's about a 7 or 8 after starting with a 20. We also worked with her on our blood sugars with more education about diet and exercise and diabetes education, focused on her monitoring her glucose. She had simply stopped monitoring her glucose at all since she'd gotten depressed, despite taking insulin, which is not safe. And gradually the nurse began to work with her and the primary care doctor around increasing her NPH. And you can see that her hemoglobin A1C has also stopped to drop and are now getting into the 8.7 or 8.8 range. Still too high, but definitely improving. One of the things we had to develop for this grant was that a register so that we can actually work with the nurses on a weekly basis and see all the key parameters on the cases they followed. So although I only printed about 5 cases here, the nurse and I can actually look on a sheet with about 25 cases. And what you see here is you get the enrollment date, and we also have the date of their last visit. And then we have a PHQ-9 at the initial one at baseline, what it is now. The asterisks represent that people have not gotten at least 50% or more better. And you can see with blood pressure, we're also following an initial one, and then where they are now, and we're hoping those go down over time, and similarly for LDL levels. And what we did in the caseload supervision is we'd start with new cases, and then we go to cases that had asterisks, cases that should have been better by 8 or 10 weeks, but were not, so that we could make timely medication changes. And this is invaluable in doing this kind of collaborative care work. Again, we developed a range of patient self-care materials, including a book and video on depression, which we had developed for a previous trial. We developed a lot of educational materials. The nurses providing a lot of support and education by their interactions with patients. The patients with complex medical regimens were given Medisets. Group Health gives those out for free, but a lot of these patients hadn't taken advantage of that. Whenever we added a medicine, this is an interesting population because a lot of them were people who had these illnesses for a while and were on 7 or 8 medicines. Some of them on 12 medicines. And so when you start to talk about an antidepressant, one of the first things a lot of people would say is, for God's sake, don't give me another medicine. I'm on 8 medicines already. I can barely keep track. And we'd agree with them. So what we did is we would go through the list of meds and we try to form a rule that for every medicine we took, we prescribed, we try to take one away. And we were largely successful with that because in most systems of care, doctors keep adding medicines, but nobody looks back and says, actually, do they need all these 10 years later? And our geriatric patients suffer from that. Again, even though group health has relatively reasonable medicine benefits, you have to pay a $10 copay for a medication. In fact, the generics are cheaper nowadays. And we did this study during the recession, when the recession hit, and a lot of people lost their jobs or benefits, or both. And so we actually had to send people out to outside pharmacies for the because the medicines were cheaper there. Again, this is the health book we've developed on depression. I could give you more information if people are interested on that. Patients were also given a range of tools. If they had hypertension, we gave them about a $12 Omron blood pressure machine. This is a wonderful, actually, I didn't realize going into the study that the technology on home blood pressure monitoring has gotten so good. But basically, you show people where to put the cuff on their arm. You push a button, and they get a very accurate blood pressure. So what people with high blood pressure did is they began to monitor their blood pressure at home, and then they bring in a graph of that to our nurses. Now, actually, it's important because particularly depressed people, a lot of them have white coat hypertension. So when they go to their doctor, their blood pressure is 10 or 20 points higher. So the home blood pressure readings are actually better than what you get in the clinic in a lot of time. We also gave patients, group health gives people glucometers, but in a lot of cases, the patient had lost them or broke them or didn't know how to use them. And so we made sure they had a usable glucometer so they can check their blood sugars more frequently. And then if they had a self-care activity where they wanted to increase exercise, we gave them about an $8 pedometer, which basically measures your steps per day, and was a way we tried to, in a sense, reinforce the behavioral activation. Patients also filled out goals with the nurses, and they were given this sheet of paper at the end of the day, at the end of the visit, about what their goals were for that time period before they saw the nurse again. They had a similar one that had all their meds and what their target goals were for like hemoglobin A1C, blood pressure, and where they were now, so they could see why we were raising meds when we needed to. One of the things our nurses asked us initially was, there's so much to do. Someone comes in and their blood sugar is 9.0% and the hemoglobin A1C, their blood pressure is too high and they're severely depressed, and we feel overwhelmed. We don't know where to start. And patients basically taught us where to start, because basically if you didn't start with depression in most people, you couldn't accomplish the other goals. And so in most cases, we intervened pretty aggressively with the depression, with behavioral activation and antidepressants first, and then began to phase in working with their other medical condition that was in poor control. Now, when they got to the medical disease control, when depression was improving, the nurses were basically educated to ask 4 questions. First, if they were on medicines, were they adhering to them? And we found a lot of people had simply stopped their meds when they got depressed. So you'd see their statin, their cholesterol level the year before, their LDL was 80 the year before, and now it's 150. Well, I can tell you statins work really well, and you don't go from 80 to 150 if you're taking it. And so we found a lot of people had just simply stopped it, and we'd try to reinforce getting back on and why that was so important. If they were adhering and in poor control, were they on optimal dosage? And this was a big problem, just like that intensification data I showed you earlier. A lot of people were on minimal doses of meds, and we could improve those and improve their care by intensifying treatment. If maximal dose had been reached, should a new medication be tried instead of augmentation? So, about 10 years or so into having type 2 diabetes, your oral hypoglycemics stop working, or they don't work as well. And many people need to switch over to insulin. And again, some of these people had been told that before, but have been reticent about it. Some of them had not been told that might be a good idea. Again, team recommendations on meds were made by the psychiatrist and the primary care doc we're supervising. We had access to the medical records, so we could look up lab tests. We'd always have a computer there during supervision, so we could look up in the EpiCare system at Group Health any recent changes in their lab tests or medical condition or new consultations. The nurses in the study asked physicians, the primary care doctor who had known them for a long time, about whether they could get physician approval for gradually increasing insulin. And one of the issues with insulin is you may be increasing very slowly, like 2 units every 3 days. And the nurses and the doctors felt it would be easier for the nurse to gradually do that and not have to come back to the doctor with every small increment. And again, they used the Group Health and Kaiser guidelines about how to do those incremental changes if the doctor agreed. Again, the behavioral goals patients often set were around activation and exercise. We especially like this one because the truth is probably exercise probably helps both depression and diabetes. So if anything, we would try to do some motivational interviewing towards more exercise. And for a lot of people that just meant walking more, using the pedometer and walking more. Dietary changes, checking insulin and blood glucose or altering insulin, and cessation of smoking were other common behavioral goals. So remember again this lady I presented who started out with a PHQ-9 of 20 and a hemoglobin A1C of 9.6. And you can see that she's done well over time, and now her PHQ-9 a year into the intervention is down, or about 9 months into the intervention is down to about a 7 from a 20. Again, in addition to the initial focus on increasing NPH and improving glucose monitoring, the nurse began to work with her on nutritional counseling, increasing exercise and weight reduction. And this patient, once her depression went away, remember she had a BMI of 51, very, very high, she decided that she would like to see if she would qualify for the Group Health Gastric Bypass Program. And to do that, you have to go through a major series of hoops, including going through a class where you agree to, where you exercise and watch your food portions and demonstrate some weight loss. Otherwise, you don't get to the bypass. And she was able to accomplish those goals. And you could see 9 months later, her blood pressure is down about 20 points, very significant. Her LDL is down, and her depression is much better, and her hemoglobin A1C has dropped into the 7 range. Now, what about the overall outcomes of the study? That's an anecdote. Well, again, what we found is we looked at the 4 major outcomes. The SEL is the depression outcome, which is a depression severity score, hemoglobin A1C, systolic blood pressure, and LDL were the key 4 outcomes. And across all 4 of those, we saw significant changes. And this change in SEL that's present at 12 months, again, continues to be present at 24 months. Here's the change in hemoglobin A1C. Intervention patients have a decrease of about 0.58 compared to controls. The intervention patients have a decrease of about 5 points compared to controls. They started somewhat higher as well. And this is the difference in the hemoglobin A1C, which is about a 9-point difference between interventions and controls. So across all 4 disease parameters, this intervention had a very nice effect. We also looked at the quality of care issues. This is, did they have at least one medication adjustment for those who were in poor control of their depression, blood glucose, blood pressure, or lipids. So this is oral hypoglycemics, insulin, antihypertensives, LL is lipid-lowering drugs, AD is antidepressants. And you can see the intervention group are more likely to have one or more adjustment of meds, and 3 of the 5 groups are more likely to have 2 or more adjustments. And we recently looked at, we have a paper coming out on some more about this treatment titration. And this, what you see here is the speed of onset of changes in these 4 classes of meds. And in every one, you're seeing that the intervention group are having much more aggressive changes in meds than the control group. And again, in the interesting thing is that we had to feed back to the docs every 6 months how patients were doing on their hemoglobin A1Cs and lipids. And despite that, we're having a significant effect over time in quality of care. We just ran some data. We have a paper in press in the archives that's looked at cost effectiveness of the intervention. And the intervention is associated with about 3 to 4 months more depression-free days over a 24-month period. And that's a really heartening effect. It's about what we found in the TEAMcare study and about twice as good as we found in the last study of diabetics alone, that is the pathway study. In other words, by working with diabetics, not only helping their depression care, but helping their diabetes and heart disease care, we actually had twice as good effect on depression. And again, my own belief of that is because of these adverse bidirectional effects of these illnesses. You really need to take care of both of them. We also looked at 24-month outpatient costs, and you can see that the intervention group has about $500 less outpatient costs over a 2-year period. So it's not only associated with better intervention effects in terms of their blood pressure and hemoglobin A1C, LDL, and depression, but we're also seeing evidence of cost savings. Now, having said that, the confidence intervals of these are wide and they would overlap, and probably the most conservative way to say this is for no greater cost, you're getting better outcomes. We also did an interesting thing. It turns out in fee-for-service care, unlike group health, which is a capitated population, doctors, if they have a diabetes nurse in their practice, can actually order up to 10 visits with a diabetes nurse to try to improve diabetes outcomes. And Medicare will pay $54 per visit with the diabetes nurse. So what we did is we basically estimated if you could actually bill for the diabetes nurse, which group health couldn't do because it's a capitated system. In fee-for-service care, the cost savings would be more like $1,100 per patient. So you'd actually see, there's actually a better business case for TEAMcare in fee-for-service care than there actually is in a capitated model of care. We also looked at the potential cost savings per quality adjusted life year, and we found that there's a $1,700 cost savings per quality. And you can see the confidence intervals do overlap with 0, and so there is a possibility it costs somewhat more to get the qualities as well, to get the improvement in qualities. The important thing here is that the Gold Commission, which sort of developed this whole idea of when we develop new interventions, we could see, we should look at what is the effect on quality adjusted life years, how do people live over the rest of their life in terms of the quality of life. And they basically said anything less than $20,000 per quality should be rapidly disseminated into care. So even if we look at this conservative $2,800 more per quality, and it could be $2,800 less too, this would be what the Gold Commission would say is an intervention that should be rapidly disseminated. We also looked at how many of these folks went below guidelines on 3 of the medical outcomes or had a significant clinical change. And you can see here this was significant, 37% of intervention patients versus 22% of controls are either below guidelines on these 3 measures or had a significant clinical change, like a change in hemoglobin A1C of 0.5 or more, or blood pressure of 10 or more. We looked at satisfaction with care, and what you see is that over 12 months, our intervention patients at 6 and 12 months are significantly more satisfied with the depression care, although at baseline they don't start any different. They're also more significantly more likely to say they're satisfied with the care of their diabetes or heart disease, again, although there were no changes at baseline. We've looked also at how does our intervention compare to interventions that only try to improve depression care or only try to improve diabetes care, like hemoglobin A1C, because almost all the interventions in the literature have only aimed at one disease. And what you can see here is that our depression effect size was 0.65 in this trial. The effect size across 37 collaborative care trials in a Cochrane collaboration study was 0.25. So we actually had a much greater depression effect than what's been seen in trials that only try to improve depression. Our effect on hemoglobin A1C is also greater than diabetes trials that only try to improve blood sugar, 0.58 versus 0.42. And our systolic blood pressure effect is greater than the mean of 4.5 that was seen over 44 trials that focused on try to improve blood pressure alone. So I think we could say our effects are quite good compared to the literature, despite taking on multi-conditions. So in conclusion today, this new health service intervention, TEAMcare, we think is a really new way of approaching care for folks with multiple comorbidities. And there's an economy of scale to that. What I mean by that is it's going to be very hard for most healthcare systems to afford a different care manager for diabetes and for heart disease and for depression. There's no healthcare system I know of that's rich enough to do it all. And so thinking about who are our most complex patients who do the worst in our medical systems and have these adverse synergistic kind of effects is a nice way of thinking about it, I think. And we think this TEAMcare model is a promising approach to improving both both depression care and medical disease control. For those of you who are interested, we've developed a very nice website on TEAMcare. You can access it by something called TEAMcareHealth.org. TEAMcareHealth.org. It has a lot of our citations in it. You can download the nurse manual from it, as well as the patient manual. And it has a lot of really good information for systems of care that are interested in TEAMcare. And this website has also helped us because we're actually disseminating TEAMcare to multiple systems of care. We're working with systems of care about how to set the program up within their unique system and how to adapt it within their unique system. So why don't we stop at this point, and I'll be glad. Looks like we got about 10 minutes to take questions. Questions? Hey, Chris.
About 15 years ago, looked at utilization by families when a person was treated in the mental health service and found that the overall utilization went. I was wondering if that's anything you've looked at when you treat people that their families utilize less too.
Yeah, again, it's an interesting question. We haven't looked at that with families because, interestingly enough, we started our group health work with a study of high utilizers, and Kathleen Myers asked us if she could plug into that study and look at whether the kids of medical high utilizers were also high utilizers, and it turned out they were. So it could make some sense that you might have some effect on the families as well. And obviously, having a person in your family that's depressed and doing poorly medically, it's a stress to the family. Yes?
Did you look at if there is any decrease in treatment resistance for the depressions? Because, notoriously the standard of care outpatient is not, it actually breeds treatment-resistant folks.
Right.
So I wondered if this aggressive dosing was actually helpful.
Well, it certainly, it was in terms of our depression outcomes are much better than usual care, and we really intensified treatment. This is a tough group of people. Most of these, I would say 70% of this population had double depression. That is, when you ask these people, when were you last well, 70% said more than 2 years ago. When were you last well in terms of depression? 70% said more than 2 years ago. So most of them had had chronic depression for many years, often with bursts of major depression. So a tough population to treat, and a lot of them got augmentation therapy. I would say it was probably at least half of them wound up on more than one antidepressant. And I think that's pretty typical of treatment-resistant populations. John?
Did you measure the satisfaction of the care providers through this? And how did they like doing this treatment?
We didn't in this study, partly because it's gotten tougher and tougher to get doctors to fill out before and after measures because primary care systems are so stressed. We did do that, Jürgen did that in the IMPACT trial and found that the doctors really liked it. I can tell you anecdotally, we were doing this, group health had developed intervention for what they call complex high-cost patients that was going on parallel to ours, and largely didn't have diabetics. I mean, it wasn't only diabetics, it's all complex patients who have multiple hospitalizations. And at the time these two were going on, the doctors basically loved our trial and were bad-mouthing this other one by saying, we don't know what these nurses are doing, they never contact us. The patients tell us that they're being seen by somebody else. And it turns out that's true. They don't have any contact with the doctors in the other program. So anecdotally, the docs were very happy with it. Group Health is piloting this in one of their... Group Health, when we finished this, went through about a 3-year process, or longer, of developing their primary care system into a primary care medical home, which frankly, caused a lot of chaos in the system. So anytime you change a system, it changes things pretty dramatically. And Elizabeth Lynn, who works with me, is now piloting TEAMcare in one of those medical home clinics. It seems to be going very well, and the idea is to spread it out from there within Group Health. John?
Is it possible that you've, because of dissemination of care in Group Health going on unintended, and that you're, in a sense, poisoning the well, and that the quality of usual care is improving and making it harder to measure changes?
Yeah. Well, again, we've been doing, our first collaborative care intervention at Group Health went on in '95. And between Greg Simon and us, we I'm sure have done 10 trials. And the system of care has gotten a lot better. 60% of patients in primary care, when they get their first diagnosis of depression, get a PHQ-9 now at Group Health, which is dramatically different than 20 years ago. So there's no doubt the system has improved. And also, they've had dramatic quality improvement efforts for diabetes for 20 years. For instance, they went from about 25% of people on statins 10 years ago, 15 years ago, to now it's like 75, 80%. All diabetics, by the way, are recommended to be on statins. So we were, in a sense, intervening in a system that I think is much better than the average system of care. But not to say that there still can't be things that could be done.
You could underestimate the power of these
Yeah.
interventions.
On the other hand, it's one of the advantages we've had in Seattle is to be able to work with a system of care that really wants to do these kind of interventions, which is not easy in the real world for a whole variety of reasons, as Doug knows.
Yeah, and Harvard, so the Harvard perspective, those nice, this is Kay, those nice graphs, gets to the exercise machine and, does all the nice educational stuff. Like the Harvard story is recurrent something, job loss, trauma, like right in the middle of that chart. But
Right.
You're working here at Harvard, you're doing the Dawn study. Like how would you take what you found at Group Health and how would you kind of re-synthesize it for our population?
Right. Doug is talking about, we have a study going on in the OBGYN clinic that Carmen, somebody pronounce her last name, Kraiku is working with us on. It's going on in 2 OBGYN clinics, both here at Harborview and University. And our population at the OBGYN clinic here, is much, I think, very similar to the rest of Harborview. A lot of folks, a lot of women in real distress and tremendous poverty and socioeconomic issues. And we've had help our nurse care managers with what we call a better engagement. So their first session is what we call an engagement interview that Nancy Grote has developed, that a lot of us have adapted, particularly to poorer populations, but I think should be done for everybody. And it really basically helps understand the patient's explanatory model of illness, helps with motivational interviewing, and helps really kind of get them on board about what is depression, how do they think about it, how does the care manager think about it, and also helps get them on board about understanding treatments. And that really helps. And then secondly, the other difference here is our care managers have to do a tremendous more amount of traditional care management. We've had 2 patients at the clinic here where their husbands were deported, both taxpayers, by the way. And our nurse actually found an SU lawyer who took on both cases, one of which has went well, one is still ongoing. That's just one example, but our care managers have had to be very creative in terms of helping this underserved population, because just getting them to come to the clinic is very hard on a given day, and they do a lot by telephone. So you really do have to adapt it to different populations. Yes?
There was very robust positive findings, but you didn't mention anything about the more malignant outcomes like suicide or hospitalization, which also true to that.
Well, we'd love to say something about suicide, but it's about a 1 in 100,000 event. So you really you need a huge study to say anything about suicide. So we can't say anything about that. There's no more hospitalizations mental health-wise in interventions than controls, and there are very few on either side. It's like a couple, one or two on each side. because almost nobody gets hospitalized in Seattle anymore who just has depression, at least in a system like group health. So, medical hospitalizations, if you look at, say, 1 to 3 hospitalizations, there's no difference in the two groups. And partly, I had to review every hospitalization, which was a pain in the neck in this study. Most of the hospitalizations had nothing to do with their diabetes or heart disease. There was elective hospitalizations. There was someone had a cyclical episode. There was a whole range of things that geriatric populations get admitted for, much of which doesn't have to do. And remember, these people didn't have just one disease. They often had 4 or 5 diseases. So again, I would love to look at hospitalizations, but we need a grant with probably 10,000 people to do that well. Basically we were looking at hospitalizations just to ensure we weren't causing harm, because there is the Accord trial which found in several thousand diabetics that by being too aggressive in hemoglobin A1Cs, they had more deaths, and they actually had to back off, and we didn't see that in our trial. Other questions? Yes.
There's an extremely comprehensive intervention. Is there actually, in terms of the quality of the results, is there anything that you wanted to do but couldn't implement from a system standpoint or from a resources standpoint that you think could have actually made it even more robust or
Sure.
efficacious?
Well, again, I think the main thing I would say to that is that it's a 1-year NIH study, which we're limited by funds. Most of these patients could use some ongoing contact after the 1-year period. So although we saw the big changes in their medical parameters, they do start to close by 24 months, and I think it reflects some of that usual care is getting better as the docs are seeing the abnormal tests and doing something. But some of it is that these are people with lifelong health habits that are problematic, and that the idea that most of the visits we did were in the first 6 months, and the idea that 6 months is going to take care of the rest of their life is probably not true, and you probably need to think about some more maintenance treatment over time for these folks if we're going to really maintain them in terms of secondary prevention. Because these are the people who really have their disease. They're at grave risk based on poor control, and systems of care need to think kind of more long-term. Now, the problem, having said that, is group health can think more long-term because only about 5% of these folks disenroll a year. In the typical HMO in the East Coast, over 50% of people disenroll each year. So the idea that you're going to do a long-term investment when half your population disenrolls, unless we change the healthcare incentives, is not going to happen. Any last questions? Well, thank you, and I appreciate everybody's questions today, too.